We're gonna get going, and we'll get right into it. This panel will be discussing the structural determinants of health with four experts who will be answering your questions. So I'm prompting you that we are looking for questions from you. So today our panelists will be Ilera Falsatoni, who is a senior economist in the Payment Systems Studies section of the Federal Reserve. Taylor Rogers, a doctoral student in the Department of Health Policy and Management at the UCLA Fielding School of Public Health. Joanne Spetz, who is a faculty at the Health Force Center at UCSF and director of the Philip R. Lee Institute for Health Policy Studies at the University of California, San Francisco. And Jeanette Dill, associate professor in the School of Public Health at the University of Minnesota. Thank you all for joining us today. So let's start by asking just a little foundational question. And this is kind of an open question to whoever would like to take this. What are the social or structural determinants of health? What does that mean? And I will call on you. I should warn you.
I'll jump in because
Yes.
this is not my own personal area of research work specifically, but at the Philip R. Lee Institute for Health Policy Studies, it is something that we pay a lot of attention to. It's essentially everything that Admiral Lavin said, except focusing on the structures. What are the structures, the components, the systems that we have established that reinforce and perpetuate differences in social determinants of health? So that can be housing policies that perpetuate difficulty for people finding housing that then affects their health. This could be the ways insurance is structured so that some individuals have exceedingly high copayments they can't afford. That's a structural determinant of health. There are some of us at our institution that also have been looking at industry and industry's role as a structural determinant of health, such as the lobbying and the actions of sugar industries or chemical industries that then perpetuate inequities in who gets what kind of diet, who has what kind of chemical exposures, how does that affect their birth outcomes, how does that affect their risk for Alzheimer's disease.
Mm-hmm. So would that include political factors as well? So, for example, the Admiral talked about states that had not expanded Medicaid.
That would certainly be a structural determinant, is policy would go into the structural determinants, and then also things like workforce policy, since we're mostly here, at least those of us on the stage are workforce nerds. The adequacy of your supply of nurses, the kinds of structures and payment systems that support or don't support paying direct care workers like personal care aides a living wage. Those are also structural determinants of health.
Mm-hmm. Anybody else want to chime in? Do you think we've got that? I have a few scripted questions I'd like to start with, and then we'll open it up for more of a dialogue. So, considering the challenges to the health workforce that we've discussed today, and based on your own research, what aspects of the healthcare system would benefit most from a greater focus on the structural determinants of health? And this is to Jeanette.
Great.
I thought you were.
Well, I'm happy to jump in. One of the things that I love about this question is that the healthcare system is the largest employer in the United States. The healthcare sector, I think, is reluctant to think about itself as an employer, right? And it primarily likes to think about itself as a provider of a service, and it's largely focused on patients, but it's also an enormous employer. And so my research largely focuses on what I would call the direct care workforce. Workers who generally don't have a college degree, who perform sort of the lowest level jobs in the healthcare workforce, like nursing assistants, home health aides. These jobs are performed almost entirely by women, disproportionately by women of color, and they're paid very poorly, right? So one of the things that I think the healthcare system could do is look at itself as an employer and think, income is one of the largest and most powerful social determinants of health. And think about the kinds of jobs that it's providing for all its workers across the full spectrum of occupations. Not just nurses, not just physicians, but all the jobs it's providing for all of its workers. And really thinking about its most marginalized workers across the industry.
Thank you. Well, these questions are scripted for certain people, but that you can all chime in. So I'd like to ask you, what do you think?
I'll happily jump in. So, sure. In a lot of my research, I actually focused a lot on the urban and rural divide. And so one of the issues clearly is that rural residents do have a very different socioeconomic context, right? They tend to be lower income, they tend to be sicker, but they also tend to not have access to care as easily, right? That is important because when you have to travel long distances to get care, there is a time cost, there is a monetary cost. And when you have these costs, and you can see that I'm an economist right here, what happens is that you end up delaying care or not getting care at all, right? And so the truth is that sort of like looking through the lens of this socioeconomic context is key. If you just think that that's just the cost that people have to bear, you actually miss out on the fact that people end up not getting care and potentially dying faster or getting a lot sicker. And so one of the very interesting things that I have been working for years now is actually the primary care physicians in rural areas do a lot of specialty work. And so they carry out a lot of specialty procedures. And every time that I talk about this with people, they tend to think, especially, I mean, you guys are probably a lot more in these topics to know more about it, but the average person would think, oh, it's probably just a machinery that they touch. No, we're talking about gallbladder operations done in an outpatient procedure, right? So these are actual procedures done by primary care physicians. And this is great from the perspective of these people get care. They get a much wider range of care that they will be able to get. And why is that? Well, just look at the distribution of people in the US. There's roughly a quarter of Americans that live in medically underserved areas, most of which are rural, yet only 10% of physicians practice in those areas. And if you look at specialists, there's fewer than 5% of specialists there. So primary care physicians carrying out these procedures really provide care to these people. Now, what is open for discussion, and I think there should be a ton more research on, is to what extent are primary care physicians and specialists truly substitutes? Or in other words, are there procedures for which the health outcomes might vary according to who carries them out? And of course here there's this trade-off of any care is better than no care, but where are we at once the care is provided? So I'll stop here. But
Okay, thanks. So what is the role of primary care in improving structural determinants of health, and how might that role differ in rural settings?
Well, there you go. Now you know why. Well, I'm going to keep going essentially on this part. So as you could clearly see from my first response, a lot of my focus is especially on primary care in rural areas and how that is provided. And so just to give you a feeling of how much of this specialty care is provided by primary care physicians, of course, there's different ways to define it, right? But take procedures that, on average, both primary care physicians and specialists could carry out, but specialists tend to provide them more, right? If you look at urban primary care physicians, depending on how you define it, roughly 20 to 40% at max of those procedures will be carried out by primary care physicians. You go rural, 60 to 80% of them are provided by primary care physicians. So again, I think that that's very important, and I think that that's something we should always consider. But given that, I think there's these, since we're talking about workforce issues, we can talk about how do we bring these physicians here, right? That's still a problem. How do we get this care? And I think there's a couple of things that I don't have clear answers for. It's stuff that I'm working on and I hope more people work on. One of them is foreign physicians, okay? Foreign physicians have there's this very cool program, very limited in scope, about giving basically preferential visas to foreign trained physicians to go to rural areas, so to medically underserved areas. It's very limited in scope, but it's extremely successful, okay? We don't talk about it enough. It's working, it's bringing physicians there, and foreign physicians already tend to serve essentially minorities, lower income people, rural people. They're willing to go there. And in fact, even from my research, I see they're more willing to move. Here are people that might even be willing to go wherever you put them, so let them go there. And so I think that that's one thing where we should actually talk about this more in the open forum, and even governments should think more about
Let
it.
me push you a little bit on that. Talk a little bit about these foreign physicians and licensure and the difficulty of being licensed in the United States. What are the barriers?
Absolutely. So I should have started with the fact that when I say foreign trained, I really mean physicians that did medical school training outside of the U.S. and generally, actually, how I define it is outside of Canada, the United States, and the Caribbean. That's just because of where Americans tend to go. And then they do the residency in the United States, okay? So the reason for that is exactly goes to the fact that if you're fully trained outside, it's a lot more difficult to enter the US medical system, and it's just also a lot more costly from even a time perspective. However, if you think about most people that study abroad at that point, that did a medical school abroad, would tend to be foreign anyway. And for them, this is just generally, these are people that at this point, they're trained in the US from the perspective of the residency, and the visa program can then be a way to attract them and retain them. And in a way, if you think about how, physicians are humans. I think sometimes, as an economist, I see a lot of health economists that think, oh my God, these are firms. They are firms, but they're also people. And they like their families, and they like their networks, and they like their personal network and professional network and their amenities, right? So, but if you have people that don't have that, a foreign person would not necessarily have a family in a place, they will not have picked a residency in a place where the family already is, it's easier to move them, right? I mean, my family is in Milan, and I'm clearly nowhere close. So right now, I'm even in Louisiana, as my hair is clearly telling me. But anyway, my Milanese parents would be ashamed of my hair right now. But besides that part, I think that's something we could invest more. The quotas are very, very strict right now. They're very tiny. Not every state does them. So that's one thing that I think we could improve on.
So I'm gonna continue along this line. Actually, I just returned from Cuba, where I visited the medical school there, where I met about 20 American citizens that were studying medicine in Cuba. When they come back, what are they going to face?
That's an excellent question. So depends where you studied, of course, and I could talk quite a bit more about this from the research perspective. There are problems, of course, in terms of also American citizens that go and do medical school abroad for other reasons other than, the pure training. It might be that sometimes they don't get into med school in the US. That could be a lot more problematic, and that relates a lot. If you come to my presentation tomorrow, you'll hear probably too much about it. You won't hear about this anymore at Less Story Life, but it is a very interesting perspective in also these sort of incentives to go out sometimes, and that's why I exclude the Caribbeans, where, for example, there's a lot of medical schools that target Americans that do not get into med school in the United States. And for them, that becomes a problem because they're often, from the perspective of their quality ladder, if you think about the medical school education, they tend to be lower, which means that they tend to enter into a residency at a lower ranked place, which means that often they also they face other challenges, and usually those challenges are extremely high loans with very low job opportunities. But outside of that, as long as you, instead of, like, for example, somebody who trains in a med school that is not in this scenario, then what they will face is simply, quote unquote simply, as long as they enter into a residency in the US, at exit of the residency, they will be able to sort of go and get a job, just like an American that goes into an American residency, depending on whatever rank they have. The problem with a foreigner, and I would know because I'm clearly a foreigner, is, of course, I mean, have you ever dealt with USCIS? It's terrifying. I would never even say that if I wasn't already a green card holder, right? Like, I mean, oh my God, right? Like, years and years of visas and inability to necessarily stay in a place. I think it's something that then people are terrified about, and they don't have necessarily the job safety at that point.
Okay, let's switch gears a bit. And
Yeah.
this one is for Taylor. What would you consider best practices when it comes to improving structural determinants?
Ooh, that's a good one. Well, actually, could I backtrack on one of the other questions? I
No,
had
you
some.
can't.
I
No.
can't.
Of course you can.
Yeah, so I was thinking about other ways that structurally we can think about reducing inequities, and I think about primarily my research centers like clinician well-being, and I think I think about how that starts in the learning environment. And I think a lot of conversations are happening in the medical school context, but I think we need to extend those conversations to what happens pre-med, so undergrad and even high school. There's a lot of work that's being published around burnout, right? And burnout starts I mean, they say it starts in medical school, but I would imagine it starts in undergrad, trying to meet all the requirements and try to get your major requirement in. And then even before undergrad, the pressure of the standardized testing. So I think when we're talking about systems and structures, we need to get creative around how do we get our physicians and healthcare workers in a better state of well-being? Because if you want to think about representation, there's a huge underrepresentation of Black male physicians, for example. And when you think about all the barriers that they go through the course of education, I think we need to get creative around how we educate them, not so much how we educate them, but what do they have to do, what hoops and barriers have to get jumped over to get to undergrad, to get through medical school, residency, fellowships if you want to, and then so on and so forth. And then to want to stay in medicine after going through all of that.
So what are we doing wrong? I mean, so you talked about Black males, which is about 4% of the physician workforce in the country. In 1965, it's about 4%. In 1985, it's about 4%. In 2005, what are we doing wrong?
I don't know if I can pinpoint that to one particular answer. I mean, in my work,
Take two. You can give me two answers.
Yeah, okay. So I know in some of my work, I know that there's a lot of things happening in the workplace. I'm seeing that when we think about the interaction with patients, there's Black men, Black physicians, and I would broaden this to indigenous physicians as well, are experiencing just high instances of racism from their patients as well as their colleagues. So I would call it a violent work environment, and that's a thing. And then you have it coming from the patient side as well. So I'm thinking something to help protect our underrepresented physicians from, I mean, you would think in theory we can do this through human resources within work, but how do you do that with a patient who you can't regulate the same way you can regulate an employee?
Yeah, but you're talking about people who are already in practice. How do we even get them into training in the first place? The numbers are low. How do we get more people of color, more people coming from these disadvantaged communities you're referring to? How do we get them into training? And I'm not just talking about medicine. I'm talking about the health workforce in general. Anyone can chime in, please.
Sure, I'll jump in on that.
It's a conversation.
I think some of there's a component of just K through 12 education. We could go down that rabbit hole. But there are a lot of schools that have tried to look at more holistic admission strategies and looking at the overall person's skills, how well did they do given the environment that they were in. And that takes emphasis off things like standardized testing, which I think most of the research shows that standardized testing is a great predictor of how much money your parents had to pay for you to go do test prep, right? And not necessarily how well you're going to do as a student. At the same time, students who are the first generation to go to college face sometimes their preparation isn't good, and they need help in just study skills, dealing with college level curriculum and demands. And sometimes those students also face a lot of self-doubt. One of my colleagues, Laura Wagner, has created a first-gen RN program and is working with students in community colleges, Cal State, and University of California nursing schools to help those first-generation to college nursing students feel more confident. Most of them are people of color, and confidence is a huge factor. And having people that you can go to and say, "Oh my gosh, I bombed that test," and not feeling like their professor is going to say, "Well, that must be because you didn't study hard enough," or whatever it is. Because that kind of self-doubt then causes people to drop out. I can only imagine then from Taylor's research, if an individual who has had that much hostility against them all the way through the educational system then starts having patients questioning whether they even deserve to be a doctor, they're taking care of them, the straw on the camel's back.
Okay, well, let's deal with this issue. How then do we help bolster people who get into these training programs to ensure that when they go out into the workforce, they're better prepared to deal with that. It can't simply be resilience. I mean, resilience can really be toxic to rely on resilience, but the kind of person you're talking about required a great deal of resilience just to get into the program in the first place. So their well of resilience may already be dry or close to it. What can we be doing, those of us that are on the academic side, what can we be doing in our programs to help bolster these students to ensure that they can go forward? Okay.
Well, I'll just chime in and say that I think, we're talking about this issue in the medical profession, but it's also an issue that is in a lot of fields, right? And in economics, it's awful. Okay, let's talk about it. I mean, I think the average person has no problem saying that economics is awful, and this is yet another reason. I mean, that's just true. But I think that one of the things, right now, it's a very topical discussion in econ going on right now, right? And it's across race, it's even across gender, it's across every single minority that you can think about. And I think that a lot of the movements that we're having really think and focus on things about like mentorship, right? But mentorship early on. And so I think it is imperative that not only the senior people do so in the field, but even junior people in the field, that we start intervening and really mentoring and educating students about opportunities early on. And so I think that there are institutions that they are doing a ton about this. I mean, I can think, again, in economics, I can mention that, for example, within the board, we do actually outreach to high schools. We go to historically black colleges to actually go and talk a little bit about that. I mean, of course, being the board specifically in DC, we have a Howard right there. We have a very strong connections. We teach classes there. The economists at the board go and teach. We have training of our research assistants and whatnot to do so. But even across other institutions, like I'm an affiliate scholar at Haller-Huwich. It's an economics institute at University of Minnesota. My alma mater for my PhD. That's how I became affiliated with them. We do women in economics mentorship. We try to reach out to students, and really it's a lot about opportunity, because I do think that there's a ton about even just not knowing how to approach the processes, that if we do not address this early on in the system, and that's why going to high school students is so important, when it's not too late, when you haven't already made these decisions for the programs. And again, we could even go all the way to K-12, but I think we could go to daycare at some point. But
I have a suggestion on something that you could do, though.
Yeah.
I have a dirty little secret. Nobody teaches you how to be a leader or a good supervisor when you're in graduate school.
That's true.
Right? When was the did I miss the class? Right? And when you're in medical school, I mean, really, did they teach you how to be a good supervisor or a good mentor? There was no content on that. I mean, they don't even teach the healthcare system in medical school, or in most
These
now.
programs don't even teach people how to teach.
Well, yeah, right. Exactly.
And some of my faculty is here. When I came here and said, "Look, this is outrageous. We're not going to keep doing this," I got a lot of pushback from the faculty, because I said we need a required course on pedagogy.
Yeah.
But we have it now.
Yeah,
And,
but the notion of supporting students more effectively, and right, there's the how to teach,
Yep.
but there's also the reality of like a department chair often is like, oh, you seem to be the only person willing to do the job, so you're department chair now. But where did they get education? Where did they receive some training? Where did they get good coaching about how to create an organizational culture that is not toxic, quite frankly? And, I mean, I went to graduate school, I think, many years before she did, and it pretty much hasn't gotten any better for women and people of color in economics programs. Fortunately, public health, I think, is better from what I can tell. But
better at what specifically were you saying?
But and then also the healthcare system. I do a lot of research on the nursing workforce, and the number of nurses I have interviewed over the decades who have said nurses eat their young.
Yeah.
That they that there is a culture of hazing, essentially, that leaders just need to be trained to and then empowered to stomp that out.
Okay, I'm going to let that sit there for a moment, because I think that's a really important topic. I think leadership is critical, and I do think higher education is a fascinating field where you have multi-billion-dollar organizations, in some cases being run by English professors with no experience in management. That is interesting reality of higher education. Present company excluded, of course, because this is for Joanne. Structural determinants of health include the policy environment in which people live. What are some policies that might address the workforce shortage while also advancing structural determinants?
Ooh, I'm a big fan of all the occupations that we don't talk a lot about or that aren't the licensed big name occupations. So I'm thinking about community health workers. I'm thinking about the roles of social workers as navigators and supports. I would add into that advanced practice nurses. So we'll have a lot of fun talking, I think, at some point about rural care and the roles of advanced practice clinicians. Peer providers in behavioral health are a fantastic workforce that is not very well known. The more that states can do to advance licensing and regulation to empower these workforces, add professions like dental therapy that have been successful in Minnesota, and bring in a broader cadre of workers and simultaneously educate kind of the incumbent professions to not think of all of these other professionals as less than. Papers that I get to peer review that say, let's write a paper about non-physician providers. Oh, great. How about why don't we name them? Say their names, and try to empower that. And I would take that into Jeanette's work, which I think she can speak about, with the direct care workers, nursing assistants, personal care aides who are in the home, who are really the eyes and the ears of what's happening there.
Yeah, I would agree with that. I think that that is a growing workforce. I think that there's a huge emphasis right now on, like you said, community health workers and the use of community health workers to promote health equity. One thing that I think is really important to keep in mind is that we have community members working in the healthcare sector now as home health aides, as nursing assistants, but they receive very little recognition for the work that they're doing. I think, that we suddenly have this idea of a community health worker is going to solve all our health equity problems. I think we could do more to acknowledge the work that's already being done by nursing assistants, by home health aides, by personal care aides, who are, an enormous workforce already. So I think that's really important. Mm-hmm.
So we're going to open this discussion up to the audience. So I don't know where the microphone is, but if we can maybe circulate it to anyone who may want to ask a question. And while we're doing that, and this is really to any and all of you to respond to, what is one thing that each audience member can do to improve structural determinants of health? And while you think about that, I'm going to take a point of personal privilege and respond to my question myself. And I'm going to bring that together with something that Jeanette just talked about, how, I think it was Jeanette, it actually may have been you, but somebody on this side said, and it was talking about how the organizations, that healthcare organizations are organizations, they are employers. In many states, they are the largest employer. Here in New Orleans, Tulane is the largest employer here in New Orleans. So we can do more to impact poverty. We can do more to impact the health of populations by how we treat our workers, right? Because a lot of that population is our workers. So one of the things that we did do here that I'm actually quite proud of is that we have increased the minimum wage to a living wage. Mm-hmm. The state of Louisiana prohibits the city of New Orleans from increasing the minimum wage to a living wage. So while the city wanted to do it, the state intervened through a preemption law, which doesn't allow the city to do that. But the university did it voluntarily, and I'm proud of that. Another thing that I'm proud of that we did, and these are things that I think all of you can do with the organizations that you work for. I brought to the university the idea of moving some of our assets into the local community bank, which is a black-owned bank, the largest black-owned bank in the country. I suggested, and I went to the COO with this idea, and to his credit, it took him 2 seconds to get it and see the impact that it could have. And we did do that. I asked them to move about $5 million to start, and let's see how that works. The last time we talked about it, we were over $11 million with that bank. They've now opened a branch on our campus, and that partnership they've developed banking programs for our lower waged employees who now are banked. These previously unbanked people who now have a bank. They do educational programs, and I think that's been a huge impact. just by doing that, just by raising the minimum wage and helping people to become part of the banking system, I think that we had a big impact on the city, on some people who have been in poverty in this city. These are the types of things that organizations can do, because universities are more than places that just create new knowledge and impart that knowledge. We are employers as well, and we have an opportunity to have a direct impact. We could do more. We could look at our healthcare benefits that we're offering, and whether or not the benefits are sufficiently covering mental health services, behavioral health services, for example, and other services. So there are things that we can do. Now that I've filibustered long enough to give you an opportunity to have thought about it, I'm going to turn to the panelists here and ask you, what would you suggest to people in the audience that they may take back and maybe implement within their organizations?
Well, I'll build on what you said, and I'm thinking in the workforce lens. We could get into all the poverty alleviation that we should be advocating for. But UCSF has been having conversations with the community that our newer campus is near in the Mission Bay area, really close to Hunters Point and some other communities that are lower income and have had a lot of job losses over the years. They've been having conversations about the simultaneous problem of our own workforce shortages, plus a lack of educational and job opportunities in these communities. And so they're like, well, shoot, we should have a collaborative program that's vocational education in a high school there. We should build the labs. We should have students in high school be learning how to work in clinical labs, how to work as nursing assistants, how to do all of those things, and offer then the structures and the tuition supports that those who want to continue on and pursue higher degrees can do so, but that they also will have living wage, high quality jobs right there in their own backyard, and that we should be involved in that education from the get-go as part of being a good community member.
Okay. Anyone else want to address that question?
One of the topics I'm going to talk about tomorrow is a really powerful mechanism for improving the wages of direct care workers and for other low wage workers is unionization, and it's one of the strongest predictors of higher wages for direct care workers. And so obviously some states are more union friendly than others, but I continue to be an advocate for pro-union for direct care workers because it has a huge impact for that group of workers.
So do we have any questions from the audience?
Thank you for bringing together a great group. I wanted to kind of build off the comments that Elena made earlier about the immigrants in healthcare workers and workforce, and hear a little bit more from Joanne about the nursing workforce and the role of immigrants there and any ethical issues and the policy implications that might have been happening over the last few years around that, and also for Jeanette to also talk about that related to the direct care workforce.
Oh boy, for the nursing workforce, I had the pleasure of being involved in a project with Polly Pittman from George Washington University, where they surveyed nurses who had immigrated from a variety of countries. The dominant country was the Philippines, about the recruitment practices that had been engaged in. And the results were really depressing. I don't remember all the percentages, but things that should never happen, like your recruiting agency keeping your passport until you've completed your 2-year commitment. Your recruiting agency demanding collateral from your family, so basically putting a lien on your family's land until you have completed your employment commitment. Talk about an opportunity for labor exploitation, right? Then you take that nurse and you place them in a hospital, and the hospital might treat them terribly, right? They might be subjected to harassment, to low wages, to any number of things, abusive patients, who knows? And they have no protection. They have no recourse. Somebody else has their passport, and if they leave, their family's going to lose land or lose all their savings. And so that kind of exploitation you'd think should not happen at all, and it does. It was documented. And so I think that's something that we need to be really cautious about in international migration. Never mind that the countries from which we often recruit surely need their health professionals too. So it's like immigration is great for the individual, but as a systemic policy and strategy, it's a structural determinant of global inequality. So, nobody wants to say like, oh gosh, don't let Indian doctors come to the U.S. It's like, no, for individuals, that's great. But should we be having a strategy of intentionally doing that rather than educating our own physicians here?
Fascinating question.
I can speak briefly to the direct care workforce. Our neighbors to the north, Canada, largely depends on an immigration strategy for staffing their direct care workforce in long-term care. They lean much more heavily in that direction for supplying their direct care workforce. And I think they run into a lot of these challenges that Joanne describes. I think countries like the Philippines really rely on the export of women into direct care roles for their national survival. It's an enormous challenge. That said, for us, for example, in rural areas, we have a huge long-term care problem, right? We have an aging population and a declining young population to provide that care. So how are we going to address that? Immigration is one way to do that. So we will see.
I also think that at the end of the day, maybe, again, this is a sort of I come from Minnesota economics, so I always think a little bit too much in general equilibrium. But one of the things that I think it comes out of something like having, immigration to other countries for job opportunities, case in point myself, is often also the fault of the job market in the country where the person is from. For example, staying exactly in my situation, Italy has a gigantic brain drain, right? We can talk about basically across every single field. That's not the fault of any individual. It's not the fault of the US or any other country where Italians immigrate to for paying more. It's because Italy does not pay its actual junior workforce. They're not interested in retaining them. They're not interested in paying enough, and they're not interested in even providing minimal level of security of employment. And so, in a way, in a general equilibrium, doing so forces the country to realize, hey, I'm losing everybody that I'm educating, and that would have been a very good asset for my own country, leading to often actual global progress. So in a way, I think, yes, it might be bad in the short term for any of these countries where any individual for their own well-being might emigrate to other countries as long as they do it with good systems and not what you were suggesting, which is absolutely awful, of course. But as long as we have good systems for that, if that's the individual choice to do so, and it's the originating country's fault for basically not paying them enough or not remunerating them enough, I think at the end of the day, it actually creates global progress across. So.
Okay, we have the next question here.
Hi, yes, my name is Emily Harris. I'm on the faculty for health policy management, and this might be a little bit more of a management question than a public policy question, but I'm just kind of curious with y'all's experience. Something I've often seen, when I was working in healthcare, was the lack of career ladders, especially for people in direct patient care, a little bit for nursing as well. Mm-hmm. And I often saw people that just like, well, you know what, leadership is the only way I'm going to advance, and this is how we get so many untrained leaders in our workforce. So I'm kind of curious, especially to those of you that kind of spoke to further licensure and education within states, what is out there? What do you guys see for career paths for that area of the workforce?
For lower level workers, career ladders are a challenge. I think the nursing career ladder is fantastic for direct care staff when they can get access to the nursing career ladder, advancing from a nursing assistant to an LPN or nursing assistant to an RN or BSN. It can just be a powerful tool for upward mobility. So I think that, the healthcare sector can provide incredible economic upward mobility when people get access to the nursing career ladder. Other really awesome career ladder opportunities are sort of mid-level allied health credentials like ultrasound tech, right? And I think when healthcare organizations provide support for that kind of additional education, it can be a way to retain workers within the organization but provide an upward pathway. I see healthcare organizations sometimes try to create career ladders that are within an occupation. So like, nursing assistant 1, nursing assistant 2, nursing assistant 3, or medical assistant 1, 2, 3, whatever. Those are generally, I think, less meaningful, less rewarding for workers. And then you see people moving into supervision because leadership because they want to just move up, right? But I think when organizations support going back to school to get that credential, that's when it makes the biggest difference. Acute care organizations have the capacity for that because they have more resources. Long-term care does not. And also they just don't have a need for those higher skilled workers, so they do not. So the workers who are in long-term care just don't have access to those career ladders in general.
Yeah, I'll add one of the tricky things about career ladders is first, really for nursing, that's the only one with kind of an obvious pathway. But that really presumes that people want to go back to school, have the skills to go back to school, have the time, right? So you need to create structures that facilitate that. But I do worry that there's a bit of an implicit, well, what you're doing isn't good enough, that comes with overly promoting career ladders. I was really inspired by a project we were doing on peer providers, and we were in Texas doing a site visit. And the state hospital in Austin for psychiatric care has peer providers. They have a recovery-oriented model of psychiatric care. And they had established kind of a peer provider step structure. Because when many of the peer providers that we interviewed said, oh yeah, a lot of people assume that we all want to become therapists. They're like, no, actually, I don't want to be a therapist. The value of what I do is being a peer, that I don't have any power over the person that I'm working with. I'm not the one who's going to sign whether they get discharged from the hospital, right? The relationship is a very different one and is therapeutic in and of itself. And they had established kind of a step 1, step 2, step 3. The step 3 required that people be developing new programs, but it was still all around being a peer. So maybe they were doing some supervision, some training, but it really valued them in that role. And yes, the salary was going to cap out at some point in that structure. If they really wanted to make the big money, they'd have to become a psychiatrist or a therapist or something. But at least they were signaling to them, the job that you're doing is valuable in and of itself. And so for direct care workers to be able to say, this is a valuable job, you're gaining skills, my goodness, you're taking care of our vulnerable, frail grandparents who have dementia and can't speak for themselves. If we're not valuing that job adequately and telling that worker that what they're doing is highly skilled and important to our society, then we've got a bigger problem.
Agreed. Mm-hmm. So I think this one will be the last question. Is that right? Okay.
Thank you. I'm Stephen. I'm a third-year doctoral student here at Tulane. And so I'm just trying to understand this issue of the health worker shortage in the rural context. It's kind of a wicked problem. We have people who are choosing not to take training that would take them rurally. They're choosing not to go to a rural location based off its location itself. And then you have people who are not being retained in a rural location. So as we try and understand the interaction of these socio-cultural, political, and economic factors, do we have a sense of what are the major motivators in which we can intervene on to retain a workforce in this rural context?
I'd love to take that or
Yes,
start.
please do. Yeah.
So yes, so a big part of actually my research agenda has been to actually understand what incentives work and do not. And so one of actually, I think the more interesting things that I found that surprised myself was that I started looking at basically physicians and where they go and how they make their first location choice. And I wanted to understand whether the incentives that we currently have in the US are currently working and how much, because we know that they're not working that well, so why? And so one of the first things that I was looking at was, okay, we have loan forgiveness and we have salary incentives. And we have been focusing on loan forgiveness for many, many years, right? I mean, these incentives have been the same since basically the 70s as a terms of like what incentives to use. But at the beginning, I thought, well, it should be $1 for $1, right? It doesn't matter if you give me $1, if you forgive $1 on my loan. At the end of the day, it should be the same. And it turns out it's not. And it was fascinating to figure out how and why. And the reason is it all lies on the distribution of loans in the US. And in particular, if you think about a state that says offers you $150,000 in loan forgiveness, well, that's going to be $150,000 worth only if you have at least $150,000 in loans. If you have $50,000 in loans, that incentive is $50,000. If you have $0 in loans, that incentive is zero. That's very interesting for two reasons. One of them is from the standpoint of who do we need the most in rural America? Well, we first want to have some primary care, right? A priori, that's the first type of physicians we want. And if you take a primary care physician and a specialist that went to the same exact med school and they paid the exact same amount, the specialist will have higher loans because interest will have started biting due to the longer residency, okay? So first of all, in a way, by designing an incentive that really attracts the ones with the highest loans, you're attracting the quote-unquote wrong group. But the second part that I think is quote-unquote more important is the foreign physician population that I told you about before. A third of primary care physicians in the United States are foreign trained. They carry zero or very low loans. For them, that incentive is exactly equal to $0. If you take the exact same budget in the US and you redistribute it basically as salary incentives, at that point, it's $1 for $1. You get more primary care physicians that will go to rural areas. And that's simply by using the exact same budget, by using a different type of incentive. Now, even though all of this is something I found that it's very interesting, there's a second component, which is residency is long, and people tend to stay where they do their residency. And why is that? Because they stay there for so long, right? Physicians have already gone to med school after having gone to college. Their residency, years long. For specialists is, shy of a decade. By the time that they finish, they have their professional network, their personal network. They are not going to move. They're very, very costly to move. And remember the distributions that I told you a while ago? Well, a quarter of the population lives in these medically underserved areas. 10% of physicians practice there. Fewer than 5% of specialists are there. Fewer than 1% of residencies are in rural areas. There's almost no training facilities. If you want to try to retain people, you gotta send them to train them there. At least for a little bit, start training them in places where they're needed. If they start getting an attachment, they're more likely to stick around.
Anyone else want to address that? Because this is our last question.
I'll just say nurse practitioner education has done better at that because it's easier to do it in a rural area than medical education, which is part of why I think you see so many nurse practitioners in rural communities.
Okay. Well, thank you all for this very interesting panel.
Thank you.